Hello, how's everybody? We're going to do chapter 51 real quick. So let's be listening on. Kind of going to go over caring for patient with Alzheimer's disorders. Do y'all realize 51, 52, 53? Last chapters I will lecture on. Aren't you glad? Then we're going to go over some things together, okay? Um, Concepts for lecture. We need to talk about collect subjective and objective data about our patient's anxiety. We also need to look into um, with our patients, applying the nursing process to the care of these patients. And with anxiety disorders, always talk about the nursing care, what we can do, explain the role of coping mechanisms in the management of anxiety. Most of y'all probably have experienced anxiety throughout your, especially through your nursing career. Hey, um, plan non-pharmacologic nursing interventions to treat or prevent anxiety and safely administer anti-anxiety agents. That's always a big one for nurses. Don't we do a lot of medications for anxiety? So let's talk about collect subjective and objective data about patients' anxiety. Anxiety and fear cause the same physiological responses, which are a result of sympathetic nervous system manifestation. Manifestation of the sympathetic stimulation include objectives, in which are what we all should know. These include blood glucose, and increased blood glucose, increased heart rate, increased blood pressure, dilated pupils, cool skin, piloerection, and decreased GI motility when we're very, very anxious. Um, there are 4 degrees of anxiety: mild, moderate, severe, and panic. So we have mild, moderate, severe, and panic. Okay, we have all probably had some of these anxiety reactions in our lifetime, and each has a different subjective effects and observable behavior. Generalized anxiety disorder is characterized by excessive anxiety and worrying occurring for most days for at least 6 months. So that's just kind of how we characterize. So when you're assessing a patient, trying to figure out where they are for anxiety, then we would ask all those questions. The patient with generalized anxiety disorder has to have at least 3 of the following symptoms: restlessness, fatigue, difficulty with mental concentration, irritability, muscle tension, and disturbed sleep. So that's kind of the things that we have to see what they have. They had to have three of those things. And what did I say they were? Restlessness, fatigue, difficulty with mental concentration, irritability, muscle tension, and disturbed sleep. Um, it should have occurred over the last 6 months to really be diagnosed as general anxiety disorder. We see this disorder sometimes as GAD, general anxiety disorder. A diagnosis of general anxiety disorder in children requires only one of the above symptoms in addition to persistent anxiety. So, there again, we're talking about times that we're in right now. If you have children, I know some of them may be experiencing some of this anxiety. So please start listening to them, because they will probably need us to talk to them, to reassure them, to be there for them. Because they are probably know that you life has changed a little bit. They're out of school, yeah, they're excited, but they don't understand why. They've never been out of school before like this. So, you have to talk to our children about that. Patients with generalized anxiety disorder report they feel significant stress, have difficulty controlling the worry, or have related impairment in social or occupational function. Anxiety can truly um, play a huge role with some patients where they really are not able to function in a normal society. Patients with panic disorders have recurrent, unexpected panic attacks, followed by at least 1 month of persistent concern about having another one. A panic attack is characterized by an episode of intense fear or discomfort. During this episode, 4 or more of the following are present: sweating, pounding heart. Um, that's just my husband calling. I'm going to tell him real quick that I am recording, so hang on a minute. Hey, Bobby, listen, I'm recording a lecture, so can I call you back? All right, bye. Um, During this episode, 4 or more of the following are present: sweating, pounding heart, palpitations or increased heart rate, tremors, chest pain or discomfort, shortness of breath, sensation of choking, nausea or abdominal distress, feeling faint, dizzy, lightheadedness, unsteady, chills, or hot flushes. I know. I wish I could have a hand raised. How many of y'all have had panic attacks? I think most of us probably have had some kind of a version of a panic attack. Um, you feel losing control of yourself or going crazy or fear of diving. Those all can be panic attacks. Acrophobia is characterized by anxiety about being in places or situations where escape may be difficult or embarrassing, and or when help might not be available in the case of panic attack. Um, Acrophobia is commonly associated with a panic disorder. It can result in a severe impairment in social and occupational function. Patients with obsessive compulsive disorder, that's another type of anxiety. They have an obsessive compulsive disorder, which they may have excessive thoughts that commonly involve dirt and germs, numbers or counting, symmetry or order, ideas that are against the individual's religious beliefs, or sexual thoughts that are disgusting to affect an individual. Example of um, compulsive rituals or cleaning, hand washing, touching, or doing things in a certain order, or praying. So OCD people have a certain order to them. Does all OCD people need medical treatment? Probably not, but there is a large percentage of these OCD people that it gets out of control and affects the way they live, and affects that they have social problems because of it. There is no pressure for the affected individual in performing the compulsive rituals, only the temporary relief from anxiety caused by not doing these. So, the individual has to do them, or they're anxious. They have to do these rituals or they remain very, very anxious. So there's just kind of like a catch-all 20 with these OCD people that are really under treatment. Post-traumatic stress disorder is a debilitating condition that follows an extreme traumatic stressor. The person's response to the event must involve intense fear, helplessness, or horror. So that kind of post-traumatic stress has to be intense fear, helplessness, or horror. The characteristic symptoms of PTSD include the following: persistent re experiencing of the traumatic event, and that can be through dreams or through thoughts or through hallucinations, avoidance of stimuli associated with trauma, numbing of general responsiveness, and increased arousal, difficulty sleeping, nightmares, exaggerated startle response, hypervigilance of alertness for danger. They just will be very much debilitated by this post traumatic stress disorder. People with PTSD commonly have repeated intrusive memories or dreams of the event. So, whatever caused the stress in the beginning, they would just have repeated uh, dreams or thoughts of that event. Some people experience flashback in which they relive the event, believe that it's actually happening. So this can be a danger because if they relive like they're trying to protect themselves or they're in a shootout, they might actually start a shootout. So you have to really, really try to treat them. A flashback may include sights, sounds, smells, feelings from the traumatic event. People affected with PTSD feel distressed by situations that remind them of the event and avoid these situations. And that's probably good advice. People with PTSD may have difficulty with interpersonal relationships because this PTSD trauma is consuming them. So their interpersonal relationship may greatly suffer because the other person probably doesn't understand all this and they don't want to have to deal with this. May have difficulty trusting or being affectionate. Military sexual trauma refers to both sexual harassment and sexual assault in the military. Victims of military trauma are at increased risk for PTSD. Social phobia, also called social anxiety disorder, is characterized by a marked and persistent fear of social or performance situation in which embarrassment may occur. A phobia is a persistent and irrational fear. With social phobia, exposure to the social or performance situation almost always results in an immediate anxiety reaction. Social phobias, remember, is just a social anxiety disorder. It's characteristic by marked and persistent fear of social or performance situation. Um, Social phobia only exists if fear, avoidance, or anxiety about encountering the social situation interferes significant with the affected individual daily routine or social, academic, or occupational life. Physical symptoms often accompany the anxiety with social phobia. They include blushing, excessive sweating, nausea, GI distress, tremors, and difficult talking. Some people can just have social phobia to getting up and talking in front of a crowd. So you can kind of relate to that a little bit if you were really ever nervous about doing that. I know there's some of y'all out there that would probably never be nervous. I could probably call a few names, and y'all probably as a class can think about who would not be nervous. On the other hand, you can probably think about a few that might be a little bit nervous. It's hard for them to get up and speak in front of a class. Specific phobias include phobias of blood or needles. The extreme fear in the phobia of blood or needles may result in vasovagal responses, which can be serious. The patient's heart and respiratory rates initially increase due to sympathetic stimulation. When the vagus nerve is stimulated, the heart rate and blood pressure fall, potentially resulting in loss of consciousness. So it is a real can be real life-threatening emergency for phobias. So don't just blow it off because they can really have some difficulty because of it. Okay, applying the nursing process to the care of patients with anxiety disorder. Um, we need to think about what we can do as nurses. So during the nursing history, the nurse may identify the patient has a general medical condition that commonly has anxiety as a symptoms. If these patients treating the general medical disorder treats anxiety symptoms, in these patients treating the general medical disorder treats the anxiety symptom, that could help. The nurse assesses the physical symptoms of anxiety, which usually begins with increased heart rate, blood pressure, respiratory rate, and assess the level of anxiety. Picture in a minute the person that you know that has a lot of anxiety. How do they look? Think about it. How do they look a lot of times? Um, the nurse. The nursing assessment always includes how patients respond to their illness, how patients respond to treatments, what factors cause or worsen anxiety if these are observed. In the intervention phase of the nursing process, that's been when we're trying to get it all together as nurses and trying to figure out what we're going to do. The nurse will help the patient recognize factors that increase or decrease anxiety as a way of improving their insight. So if they can recognize these factors, sometimes it will help them to maybe prevent from getting to this vasovagal response where it is could be detrimental to their health, to their physical health. The nurse is responsible for the care of patients who receive medications and must know that the desired effects and potential effects of these medications. Again, it's all about medications all the time. The patient is experiencing an episode of anxiety. The nurse assesses the patient's perception of the threat represented by the situation. The patient's use of alcohol or drugs, self medication for anxiety at home, should be assessed because that can just cause more anxiety if they're self medicating using drugs or alcohol. So that can be a major problem. We have to address that as nurses. A patient with a history of insomnia or irregular use of medications for sleep needs to be assessed because it may indicate chronic anxiety. Why do you always have to have that medication to sleep? Do you have chronic anxiety? Then that we need to delve into that a little bit further. Information about the patient's usual coping methods can be helpful in planning care for the anxious patient. So we always need to check, see how they coped in the past, how are they going to plan to cope with this, fill them out, do therapeutic communication, let's talk to them. The nurse's own anxiety level is another important assessment because when the nurse is anxious, it is much easier for the patient to feel anxious. Anxiety is a nursing diagnosis and a possible expected outcome. Um, is that the patient will discuss feelings of anxiety and potential desire to do harm to self. So we use anxiety as a nursing diagnosis, but our outcome should be that the patient will discuss feelings of anxiety and potential desire to harm self. Okay, not that we want to hear about that all the time, but we want to recognize that so we can help the patient. Nursing intervention for nursing diagnosis of anxiety can include a risk of self harm. Again, we've talked about this over and over and over. You sound like a broken record. Ineffective coping is another nicer diagnosis. It's often used with patients with anxiety. Um, they can't cope if they're in this very anxious thing. So we need to teach the patient to recognize anxiety as it develops, taking control, stopping the anxiety from escalating. Relaxation or breathing techniques, exercise, meditation, or teaching the patient to use progressive relaxing as a coping mechanism. Another nursing diagnosis for a patient with anxiety is post-trauma syndrome. That can be one of our nursing diagnoses with a possible expected outcome that the patient will discuss feelings and verbalize situations that increase the sense of threat, fear, or anxiety. Nursing interventions for post trauma syndrome include assessing the degree of the anxiety or fear, the degree of the threat perceived by the patient, um, staying calm and staying with the patient, keeping communication simple, assisting patient to correct any distortions of thinking, help the patient identify coping behaviors that have been useful in the past. So you could always ask them, how did you cope in the past with this? Let's see if we can't go back to that and see if that doesn't help you. And identify supportive people in the patient's life because you have to get them involved to help this patient. Um, Evaluation involves gathering the data to a certain if the expected outcomes were met. If it is not, the goal of the nurse will relieve all anxiety. Some anxiety is a necessary protective mechanism that allows people to be alert. Nurses try to help patients understand themselves so they can learn new coping skills and keep anxiety at a very manageable level. So, there again, what are we doing? We try to teach the patient how to manage this all the time. Doctors will come in and prescribe stuff and talk to them, but then we are to carry out that and try to teach them how to find protective mechanisms to allow the people to be alert and to understand themselves and to help them cope. So, as I've said many times, how many roles do nurses do? Tons, 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 tons. So, we have to know all that. All right. Explain the role of coping mechanism in the management of anxiety. People use coping behaviors to adapt or manage stress to change. To control anxiety, people develop patterns of coping behaviors. Coping behaviors can be adaptive, they can be healthy or likely to lead to a positive resolution, or maladaptive. So, adaptive, ADAPTIV, or MALADAPTIVE, that's unhealthy. Um, a person who's used active problem solving while considering the rights of others is using coping behavior adaptively. A person who expresses negative or aggressive behavior towards others is using maladaptive coping behaviors. I think we can pretty much figure that out. But like I said, coping skills can be adaptive or maladaptive. We know the difference, okay? So, um, defense mechanism include acting out, anticipation, compensation, denial, displacement, disassociation, humor, projection, rationalization, reactive formation, regression, repression, sublimation, and suppression. So there's all kind of defense mechanisms. Some of them are good and some of them are not. So we want to be sure that we have positive defense mechanisms, not maladaptive defense mechanism. Um, Non-pharmacological measures. Matt came in and talked to us early in the semester. He kind of gave us some non-pharmacological nursing interventions. Those are good things to try with our patient. But every patient is treated differently. Um, there's something called cognitive behavior therapy that helps change thinking patterns that contribute to the anxieties. Those are usually led by psychiatrists. They're also led by, group therapists. So all those can be led. In exposure to therapy, patient confronts the thing they fear. One approach called exposure and response prevention is used in the OCD. For example, if a patient fears dirt and germs, the therapist may have patient dirty their hands and wait a given amount of time before they wash while the therapist helps the patient cope with the resultant anxiety. Just kind of little simple things, have them kind of face that fear a little bit. Other types of exposure exercise involve techniques such as encouraging a person with social phobia to spend a set amount of time in a feared social situation while fighting that desire to run away. So sometimes the way we overcome our fear is to do something, okay, to do that thing that we fear the most. Um, the patient may also work with patient to promote resilience. The resilience factors are self-efficiency, high functional ability, independence with the activity of daily living, good self rated health and positive outlook on life. So we also want to promote resilience of these patients, show them there's a different way to do it. Um, Behavior therapy can be used to treat social phobia. So there again, social phobia is usually just leading them to fear what they, leading them into the fearful situation they fear the most. Medications from several classifications treat this very well. Despite potential hazards of anti-anxiety drugs for a few patients, there are situations that when they are indicated, benzodiazepines are used for anxiety, insomnia, alcohol withdrawal, skeletal muscle relaxation, acute management of seizures, severe agitation, social phobia, generalized anxiety disorder, and panic disorders. The target symptom for anti-anxiety drugs are nervousness, sweating, increased heart rate, sense of dread, fearfulness, phobias, compulsiveness, nausea, vomiting, diarrhea, dizziness, irritability, headache, and dry mouth. The target symptoms are sedative hypnotics or insomnia and sleep disorders. Uh, Occasionally, patients will have some kind of different reaction from benzos. Instead of relaxation, they experience agitation or unstable emotion. So we have to really, really watch some of these drugs. Some of these drugs can kind of be some big gun type drugs. Older adults and children and people with brain damage are increased risk for a paradoxical response to benzodiazepine. That's when they're going to react totally different to the benzodiazepine. Um, and if they do have a paradoxical reaction, that's the contraindicate indicator. That's the response that we do not think is going to happen. Because usually with benzodiazepines, it's going to calm them down. But when they have that the opposite, they experience agitation or unstable emotions. We need to stop that benzodiazepine. It is not working like it's intended and can lead to more problems. Dependence and tolerance are the important concern with benzos. Overdose of benzos are not commonly fatal. Fatalities often involve combination of benzos and alcohol and other CNS depressants. So that's pretty much that for that chapter. They get shorter. A lot of this gets more and more where I know you understand it better. So just really read through the chapter, study through it, and we'll talk more. Good to see y'all. Thank you, Miss. See y'all later.